Good morning. My name is Dr. Walid Khalsuddin. I'm a cardiologist, and I will be sharing with you two lectures about valvular heart disease. The learning objectives from these lectures are, the learning outcomes of what we intend to cover in these two lectures would be what we know about the etiology of the valve pathology or disease, what effect they have on the hemodynamic derangements, how these derangements will affect cardiac structure and function in terms of hypertrophy, in terms of systolic or diastolic function, and then the clinical effects of the above, what symptoms does the patient have, what we may find on physical exam, and then when is the best time to correct these problems. There is a time. We don't want to do it too early, we don't want to do it too late. So I hope we'll be able to cover all these. Condition we're going to talk about is aortic stenosis. And the pathology usually is not very varied. There are a few important conditions that cause this. The first is the congenital condition of what we call a bicuspid aortic valve. So normally the aortic valve is, as you know, consists of three cusps. Now, during embryonic life, it's very often the cusps don't separate, and you end up usually with a bicuspid valve. Less common, you can have a unicuspid valve with only a single opening, as we'll see in the next image. The line of fusion between the two cusps is called a raphe. And the final thing to say is that this is a common abnormality. I usually tell students that in such a class, for example, the number of the students, usually there are two, maybe three people who have this abnormality. So, as we said, the classification may be congenital, unicuspid, bicuspid. The other reasons are rheumatic disease, where you have commissural fusion, which with time will lead to fibrosis and calcification. And the final cause of aortic stenosis is what happens with age, what you call degenerative calcific. These valves are not abnormal during early life, but simply with age, the valves become fibrotic and later calcified. And when the valve is heavily calcified, its opening, the excursion of the leaflets in systole becomes limited, and hence they develop aortic stenosis. So this is now the commonest condition that we see in our practice is the degenerative calcific, people above the age of 70, 80, 90 even. The older you get, the more likelihood of developing degenerative calcific aortic stenosis. This is just a schematic, the diagram of how they look. A is the normal. B is the rather uncommon condition of a unicuspid valve, where you can see only one opening. And these people present in infancy, at birth, early infancy, with pretty severe aortic stenosis, and that has to be dealt with as babies. Rheumatic, as we said, is caused by commissural fusion. The bicuspid aortic valve, which may be normal in adolescence, early adulthood, in the 20s and 30s, but because of its abnormal structure, the valve, turbulence in the flow across it occurs, and so with time you get some little trauma, fibrosis, ultimately calcification, and the valve can become stenotic or regurgitant or both. And the senile calcific we just talked about, which happens with age. So these are just images of what a senile calcific aortic valve looks like, what a degenerated bicuspid aortic valve looks like, and will lead to stenosis. And as we said, the incidence, if you look at people less than the age of 70, the majority are going to have a bicuspid aortic valve. And post-inflammatory, what we mean is rheumatic. Whereas if you look at the population above the age of 70, the majority are going to be the degenerative calcific aortic stenosis, less commonly the bicuspid, and the inflammatory will remain in the same range. Now, we have to move on to the hemodynamics. So the normal ventricle and valve on the left, and on the right is the stenotic valve. So when you have a stenotic valve, the left ventricle has to generate a higher pressure to drive blood across the narrow valve. So you have to deliver the same amount of stroke volume, but because the valve is stenotic, you have to push harder, as you just to say it simply. And pushing harder can only be done by increasing the pressure in the ventricle. So if you look at the numbers, the pressure in the aorta is around 120 or 110 systolic. And in the ventricle, in a normal ventricle, it will be the same. The ventricle and the artery distal to it usually have the same systolic pressures. In aortic stenosis, the left ventricular systolic pressure has gone up, for example, here to 200 millimeters of mercury. You may notice also that there is a rise in the diastolic pressure in the ventricle from a normal of around 10 to 25. We'll talk in a while why is this. Just keep this in mind. So how is the pressure measured? In the ventricles and in the aorta, of course, we insert a catheter attached to a manometer. You know these. And we can measure the pressure in the left ventricle and the pressure in the aorta. And the difference between the two in systole is what we call a pressure gradient. This may be you can measure the difference between the peak ventricular pressure and the peak aortic pressure. This is what you call a peak-to-peak gradient. Or if you take multiple measurements during the cardiac systole, you will have you can measure what you call a mean gradient. And we'll later on elaborate on the significance of these numbers. Now, the concept we have to re-emphasize is that the stroke volume that's going to pass through the valve, it's going to pass through the valve. If the valve is narrow, you have to increase the pressure and hence the velocity of flow of blood across the valve. This will lead to a gradient, as we just discussed, and the gradient for this pressure to develop, you have to increase the velocity. And how can we measure the velocity? We use the technology of Doppler ultrasound. As you know, we all do echocardiography. You are all familiar with this. It's daily bread and butter of cardiology. So by emitting ultrasound waves on the moving red blood cells, the moving red blood cells lead to what you call a Doppler shift, and this can be calculated into a pressure gradient. So the higher the velocity, the higher the pressure gradient. And these we use to measure severity of stenosis without having to take the patient to the cath lab every time we need to measure the gradients. So this is just an example of how it looks if you have a hose with water flowing through it, and if you apply some narrowing to the origin of the water flow, you will see that the velocity has to go up and the water travels faster. Now, if you turn down the tap, what happens? The velocity comes down, and this is at the expense of what? at the expense of a decrease in the amount of volume passing through the valve. The analogy to the in the normal heart would be in a sick heart would be when the left ventricular ejection fraction drops and the stroke volume delivered through the narrow valve becomes less. I hope this is helpful as an illustration. So, how do we do it by Doppler? We measure the machine measures the velocity of the red blood cells emerging from the narrow orifice, and there's a modification of the Bernoulli equation, which you probably remember from your physics, which says that the delta P, or the pressure gradient, is 4 times the square of the velocity. So if our machine tells us the velocity is, let's say in this case, 4.5 meters per second, then just doing the simple calculation, we end up with a pressure gradient of 81 millimeters of mercury. Of course, very conveniently, there's a formula to calculate the orifice of the stenosis, which is our gold standard to measure the severity of stenosis. Why is that? Because as we said a while ago, the amount of flow across the valve may differ, so the pressure gradient and velocity will be different. However, the stenosis is going to be constant. So the best way to measure the severity of a stenosis is by measuring the valve orifice area. I will not belabor this point, but just to tell you that there's a simple calculation, A2, which is the stenotic area. We measure the other values, the V1 and V2 we can measure, and we can measure the area simply by echocardiography, the diameter of the left ventricular outflow tract, and calculate the area, and hence we get the orifice area. What we want to remember that the pressure gradient is directly related to the amount of flow, and it is inversely related to the valve area. This is written here. I think you can just read through it, and I've already explained it. Now, what are the consequences of aortic stenosis on the left ventricle, or on the heart in general? So, as we said, the left ventricle has to generate higher pressure. So the first definition, which you know, and I remind you of, is that tension in a chamber is directly related to pressure and multiplied by the radius of the cavity. So you have a bigger radius, you're going to have higher tension. You have higher pressure, you're going to have higher tension. Now, what we care about more is what you call stress, wall stress. And wall stress is the dividing the tension by a unit of muscle. And so if we divide tension by the wall thickness, we get what you call stress. And the main principle in hemodynamics is that the heart reacts to try to normalize wall stress on the muscle of the heart. So this is how it looks in clearer terms. Tension is pressure times radius, and wall stress is pressure times radius divided by twice the wall thickness. And hypertrophy aims at normalization of wall stress. So we have introduced the concept of hypertrophy. Again, I'm sure you already are familiar with this. So, in aortic stenosis, when the main challenge is a higher pressure, this will cause the increase in tension. If you increase wall thickness and decrease radius a bit, then this will tend to bring stress down to the normal, like in ventricles with no aortic stenosis or no pressure overload. The other example of pressure overload, I'm sure you know, is probably hypertension when somebody has high systolic blood pressure. So the definition of hypertrophy is when you have an increase in muscle mass. In pressure overload ventricles, this happens by replication of the sarcomeres in parallel, so they are stacked one on top of the other. This will lead to a thicker muscle. The cavity will decrease a little, of course, not very much, because the heart has to accommodate the venous return. So a mild decrease in the radius with an increase in wall thickness tends to normalize wall stress. We'll talk later in aortic regurgitation and about the other type of hypertrophy, which is eccentric hypertrophy, where the sarcomeres replicate in series because the ventricle has to accommodate a larger volume. These are just numbers to further elaborate on my point. So if we look at a normal left ventricle, and the left ventricular pressure is 117 millimeters, this is a patient whose left ventricular systolic pressure is 226. So he has hypertrophied, so his left ventricular mass index has gone from 71 to 206. Wall thickness has almost doubled from 8 millimeters to 15 millimeters. And the radius over thickness ratio below is 34 whatever and 0.56. Or it's more of a thickness over radius. Finally, what we look at the stress below, the peak systolic stress, if you notice, they are almost equal, 151 and 161. Don't care about the diastolic now. So because of this phenomenon of hypertrophy, we have almost normalized wall stress. So is this the end of the story? No. The concentric left ventricular hypertrophy has consequences on the myocardial stiffness in diastole when the ventricle has to fill. So if we look at the middle curve, the black curve, as the ventricle is filled with volume on the abscissa, as you increase the end diastolic volume, the left ventricular diastolic pressure goes up. So at around, for example, 120 milliliters, you have an end diastolic pressure, let's say, of 10 or 12, the normal left ventricular diastolic pressure. However, with the stiff hypertrophied, concentric hypertrophy ventricle, if you want to fill it for the same volume of 120 cc's, look at the left ventricular end diastolic pressure. It goes up. Just an example, it tells you 30. So when the left ventricular end diastolic pressure is higher, 25 or 30, the left atrial pressure in diastole that has to fill the ventricle will also go up. So the left atrial pressure now is around 25 or 30. It has to be a little higher than the ventricle for the blood to flow. And if the left atrial pressure is that high, then the pulmonary venous pressure is high. And so the patient may have symptoms of shortness of breath because the pulmonary venous pressure also affects lung stiffness, etc., etc. And of course, in the advanced cases, you get something called pulmonary edema, which I'm sure you are aware of. We'll discuss this again during the 2 lectures. So a stiffer ventricle leads to a higher diastolic pressure for the same amount of volume filling the ventricle. And the upper left corner just gives you a visual idea of the situation. And this is the curve of the stiffer left ventricle. So what we call this stiffer ventricle, we call it a leftward shift in the pressure volume curve, as compared to what we'll see later on as a rightward shift in the pressure volume curve. And of course, due to the higher pressure generated by the myocytes, relaxation will be impaired, the reuptake of calcium in early diastole. Another important phenomenon is that when you have such a stiff ventricle, the atrial contribution to filling of the ventricle, which happens at the end of diastole, after the P wave of the EKG, you know, the atrium contracts. So the atrium will have to push harder to fill the ventricle at end diastole. And this is what you call an atrial kick. And hence conditions where you lose the atrial kick, for example, atrial fibrillation, become important. Another consequence of hypertrophy of the muscle is that with development of higher tension, when the ventricle generates a higher pressure, it needs more fuel, so it needs more oxygen. And so systolic tension is the major determinant of myocardial oxygen consumption. The other ones would be heart rate, as you all know, and the contractile state of the ventricle. What we care about here most is the systolic tension that's related to contractility mainly. So less important, but also contributes to myocardial ischemia is when you have a high left ventricular diastolic pressure, the subendocardial vessels are compressed, and hence there will be less flow into them, and maybe some subendocardial, what you call subendocardial ischemia. The final cause would be the lack of commensurate capillary multiplication with the development of hypertrophy. So we'll have less capillaries per unit of muscle, and this also will affect myocardial perfusion. So coming to clinical manifestations of aortic stenosis, we talked about myocardial ischemia and angina. We'll talk about another phenomenon called syncope. And you know, the definition of syncope is loss of consciousness due to cerebral hypoperfusion. The simplest would be somebody who sees a bad sight. For example, some people, when they see blood, others when they hear bad news, etc., they develop a reflex bradycardia and vasodilatation. So their blood pressure goes down and their cardiac output goes down because the heart rate is low, and the brain is no longer perfused adequately, and so they pass out. So this is very common. How does it happen in aortic stenosis? It happens, for example, during effort. Patients with aortic stenosis, like the example we showed you, who has a left ventricular systolic pressure of around 200, when this patient exercises, so he has to increase the stroke volume across the narrow valve, so the left ventricular systolic pressure may need to go up even higher to maybe, let's say, 300 millimeters mercury. When the left ventricular systolic pressure is that high, there are receptors in the left ventricular myocardium, nerve receptors, that are stimulated by this very high pressure, and they cause a reflex, bradycardia, and vasodilatation, like the fainting we talked about, and the patient passes out. Less commonly, but can also occur, they can have an arrhythmia, for example, while they're running or something. They can have something called ventricular tachycardia, or they can develop an atrial fibrillation with impaired filling of the ventricle, and they decrease their cardiac output and they pass out. The final most important consequence of aortic stenosis is the phenomenon of what happens after years of hypertrophy. So if you have a normal ventricle with pressure overload, as we discussed, they can have hypertrophy, Now, this hypertrophied muscle does well for quite a while, but with time, uh, the continuous stress that's placed upon these myocytes, the higher pressure in the ventricle, leading to ischemia, recurrent ischemia, uh, will lead to what you call apoptosis, cell death, replacement fibrosis, and ultimately the myocardium is going to become weaker, so the cavity will dilate and the walls will thin, and you develop what you call systolic dysfunction, and the whole term would be called decompensated left ventricular hypertrophy. So we had compensated when it was normalizing wall stress, muscle was thick and healthy, and now it is decompensated, and this is when they go into heart failure. Now this slide is very important. Important, and when I studied cardiology, this slide was there. So this is a very old concept that apparently has withstood the test of time. And this relates to the consequences of the complications of aortic stenosis that we already just went over. So if we look at the survival of a patient with aortic stenosis, you see that over the ages 40, 50, 60, they have a good survival. Now, when they develop symptoms, their survival is affected. The first symptom we talk about is angina. We talked about myocardial ischemia. Usually the average survival is around 5 years in this case. When they develop syncope, again, we discussed it, the survival goes down to around 3 years. And when they develop heart failure or decompensation, the left ventricular ejection fraction begins to drop, their survival may go down to around 2 years. These are all average numbers, but these are sort of red herrings or warning signals that you have to intervene in patients with aortic stenosis. Clinically, when we examine a patient with aortic stenosis, what do we hear? We hear, of course, a murmur, and this murmur is usually systolic. Usually, it's always systolic in the case of aortic stenosis because this is when flow occurs. Systole, as we know, is between S1, where the AV valves close, and S2, when the semilunar valve, the aortic and pulmonic valves close. What I want just for you to pay attention to is this red line. If you notice, this is the intensity of the aortic second sound. With more severe stenosis, you notice the intensity becomes less. Why is that? Because, as we said, with aortic stenosis, there is calcification, and the more calcification in the valve, the less excursion it will have in systole. So it will not open as well as a normal valve. And the analogy to this would be if you have a door that's fully opened and you close it, it's going to close with a loud slam. But if the valve is only open, the door is only open for 20 or 30 degrees, then when you close it, the closing sound is going to be weaker or softer. So a soft S2 usually means that the aortic stenosis is severe. The loudness of the murmur, contrary to what many people think, the louder the murmur, more stenosis, no. More important, what we pay attention to is the intensity of the second heart sound, the aortic second sound. So with a diminished aortic second sound, this means that the valve cannot open well and hence closes with a softer sound. Next, we have to get an idea about what we call the stages of valvular heart disease. There are also stages for heart failure. These are concepts that have been recently introduced by the American Heart Association, American College of Cardiology. The first two stages would be A and B, which are not very important to us. For example, if somebody has a bicuspid aortic valve and he has no symptoms and he has no gradient across the valve, then he will be in stage A. When he begins to develop a mild stenosis or mild regurgitation, but he still has no symptoms and he has normal left ventricular function, so he is in stage B. Stage C and D are when the valve pathology becomes severe, but then we differentiate between when the patient has severe stenosis and he is asymptomatic, then he'll be in stage C. And if he has the severe stenosis and he has symptoms, then he is in stage D. What about left ventricular ejection fraction? We talked about apoptosis, etc. Some people may develop LV dysfunction but remain asymptomatic for a while. They will be in stage C2. They have LV dysfunction, but they are asymptomatic. When they develop LV dysfunction and they are symptomatic, they are in stage D. And they can be in stage D even if they don't have LV dysfunction, just because they are symptomatic. So to sum up, you can have concentric hypertrophy that ultimately ends in failure. The ejection fraction declines, and the patient will develop what you call symptoms of heart failure, fluid overload, leg edema, etc., etc. What's the management? We have to replace the aortic valve when the patient is symptomatic or if he is developing left ventricular dysfunction. Usually, the definition of severe aortic stenosis is when the area is less than 1 square centimeter. Normal is more than 3 or 4 square centimeters. If we are measuring the gradient, usually in people with normal LV function, the mean gradient is around 40. But you have to remember, if they have systolic dysfunction, so there is less flow across this fixed stenosis, you can have a lower gradient. So this is why we don't care very much about the gradient as much as we care about orifice, which we calculate by Doppler or even by cath. The management of aortic stenosis, so the only option available is valve replacement. And this would be recommended when you have severe AS, but severe is not enough. They should have symptoms, or if they have severe AS with development of LV dysfunction, then this will be an indication for surgery. But severe AS per se may not be an indication. You can then follow up the patient every 6 months or 1 year for development of symptoms or for the development of LV dysfunction, at which stage you intervene. The option to treat has been surgical for 40 years, maybe 50 years, with the replacement of the valve. But nowadays we have a technique that can be done what you call percutaneously via a catheter. If you go through the femoral artery, similar to what is done in coronary stenosis, you introduce a valve which is wrapped around a balloon, and once you reach where you want to insert it, you inflate the balloon and the valve sticks to the walls of the left ventricular outflow tract, and you have a new valve in place without having to need to go to surgery. This is what you call TAVR, transcatheter aortic valve replacement. Just an idea of how this is done. You insert a catheter into the aorta down to the region of the aortic valve. Then you introduce the balloon carrying the valve across the stenotic aortic valve. You inflate the balloon, which leads to squeezing of the old leaflets onto the wall of the aorta. You deflate your balloon and you pull out your catheter, leaving the new valve in place. So this is just modern technology. This is done here at AUB, and it is a very rewarding procedure. So we shift gears now and we move on to aortic regurgitation. Obviously, this is when the aortic leaflets in diastole do not close well, leading to a leakage of blood back into the left ventricle. Of course, you know that the diastolic pressure in the aorta is higher than the diastolic pressure in the ventricle, and this will allow the blood to fall back into the ventricle. Examples of this condition would be here in this echo, showing mild and moderate or severe aortic regurgitation. Mild regurgitation is obviously on the left. And this is what you call color flow Doppler. This is how we image it in the echocardiography lab. And on the right side, you have very wide jet in diastole filling the left ventricular outflow tract of severe aortic regurgitation. This is just another example of, maybe I should have showed you this earlier on with aortic stenosis, of a bicuspid aortic valve. I think this is very clear how the valve opens. I like to liken it to the عروة الزر, or how the button opening looks like. And you see that the two top cusps are fused, so they move together while you have a lower cusp. So this is a bicuspid aortic valve. This is just for interest. So what's the etiology of aortic regurgitation? It could be due to rheumatic heart disease. When the leaflets are fibrotic, thickened, etc., they become shorter, and you have aortic regurgitation or insufficiency. You have a condition called myxomatous degeneration. You probably learned about it in pathology, where the connective tissue that forms the valve is deficient or abnormal, and you can have a weak valve that will not withstand the pressures and it will leak. And finally, these are the most common causes. You can have what you call infective endocarditis, where you have a bacteria that sits on the valve. There's an inflammatory response, but the action of the bacteria will lead to destruction of the valve tissues, and the valve will now become regurgitant. These apply to other valves, of course. We will learn about them also in mitral valve disease. Shifting away from the leaflets themselves, you can have a disease of the aorta. When the aorta dilates, so we know that the valve sits at the root of the aorta. So when the aorta itself is bigger, the leaflets are going to be pushed away or pulled away, and you will have lack of coaptation in diastole. They don't coapt well, they don't come together as we should be, and you can have regurgitation. And then there's a rare condition of what you call aortic dissection, where there's in the wall of the aorta a tear, and blood sort of enters between the layers of the aorta. This will lead to dislodgement of the intima of the aortic wall, and with it the valve leaflets. So this is an example of aortic dissection. If you see this, what you call a hematoma, there's a tear in the wall of the intima of the aorta, and you call this an intimal tear. And then a hematoma develops in the wall of the aorta, and the intima is pushed inside, and this will sort of avulse the aortic valve. If you can see this here on the right, on the left part of the screen, you notice there's a hematoma which has pushed the intima, and this will lead to distortion of the aortic cusp, which is adjacent to this intima, and the valve does not close well. So you can have aortic regurgitation from this. If you notice on this slide also where the arrow points, this dislodged intima has led to what? It has led to blockage of the origin of the right coronary artery. So this is how dissection, which is a dreaded problem, can kill a patient, because now it's going to cause a myocardial infarction in addition to disruption of the valve. And of course, it can also occlude other vessels in the body, such as the carotids, etc. So this is why aortic dissection is a very grave illness that has to be dealt with on an emergency basis. This is how an aneurysmal aorta will look like, and you can imagine that the leaflets inside have all been pulled away from each other, and you can have severe aortic regurgitation. Now, coming to pathophysiology, we have volume overload of the left ventricle due to the diastolic regurgitation of blood. And this, the consequences on the ventricle depend on whether this happens gradually. For example, somebody with rheumatic heart disease who develops gradual shortening, or with aneurysmal dilatation, or if this happens acutely, as we'll see in a few moments. Acute aortic regurgitation, what would they cause? Somebody with infective endocarditis or aortic dissection, as we talked about. Infective endocarditis, for example, in IV drug users, they develop bacteria in the blood, usually with very virulent organisms such as Staph aureus. They can develop in a day or two a severe infection of the aortic valve, for example, or any other valve. And they develop severe regurgitation overnight. And so the heart does not have time to adapt to this severe volume overload. So let's look at the hemodynamics. You remember this curve from physiology, and we discussed it in this lecture also. So if we look at the middle curve, the normal, we see that the ventricle, let's say, has filled to 80 or 100 cc's, and the left ventricular diastolic pressure is 10 or 12. Now, if you have acute regurgitation, as we said, developing overnight, the ventricle does not have time to enlarge to accommodate this extra volume. So you're going to challenge it with a higher volume in diastole. And so the left ventricular diastolic pressure is going to go up. This is what you see on the acute regurgitation curve. So the left ventricular diastolic pressure goes up a lot. Patient will be very sick. They can go into pulmonary edema. And the reason is the acute volume overload, because the ventricle has not been able to dilate to accommodate this excessive volume. Now, what would be the situation if somebody has developed regurgitation slowly over time? The ventricle will have time to dilate and accommodate this volume, as you can see on the chronic regurgitation curve. So now, for example, the LV will accommodate 100, 120, 140, even 160 cc's, double the regular volume, without a rise in left ventricular diastolic pressure. This would happen with chronic regurgitation. There's a right shift of the curve. Left shift of the curve occurs, of course, in concentric hypertrophy, the ones we talked about in aortic stenosis, for example, pressure overload. And in the middle, when there is acute regurgitation, you don't have time to change the position of your curve. So in chronic regurgitation, we talked about acute regurgitation. In chronic, the volume overload leads to gradual LV dilatation, because the left ventricle has to accommodate the blood coming back from the aortic valve in diastole, plus the venous return that comes through the left atrium. and through the mitral valve in diastole. So you have two sources of filling of the ventricle. The left ventricle has to dilate. When it dilates, the radius increases, and so pressure times radius, means higher tension and higher wall stress. So if you increase your thickness a little bit, wall stress usually normalizes. Pressure times radius times 2 times thickness. But because the problem here is the radius, not the pressure, like in aortic stenosis when it goes up from 120 to 200, because the radius increases by maybe half a centimeter or 1 centimeter. So a little increase in wall thickness will be enough to normalize wall stress. This is the example I showed you before, now extended to show you volume overload, where, as you see, the left ventricular systolic pressure has not gone up much from 117 to 138, for example, but the LV mass has increased, like in aortic stenosis. It's almost 200 grams. But now the type of hypertrophy is what you call eccentric hypertrophy. And wall stress, again, remains within normal due to eccentric hypertrophy in this case, where there's a mild increase in wall thickness to compensate for this significant increase in the radius. Again, this is another way of looking at it. The aortic stenosis, LVH, with the thick muscle, small cavity. The aortic insufficiency, AI, with a dilated ventricle and mildly increased wall thickness. So this just to reiterate the difference between chronic and acute regurgitation. Auscultation and aortic regurgitation. Of course, the murmur now is diastolic. So it is after S2 in early diastole. The moment the aortic valve closes, which is S2, the moment it closes, the valve is leaking. So you're going to get an early diastolic murmur, okay? Contrast this to the one below, where in mitral stenosis, there's a time period between aortic valve closure and mitral valve opening, what you call the isovolumic relaxation period, before flow occurs and the murmur of the mitral stenosis starts. So aortic regurgitation, the murmur occurs immediately after the aortic valve closure. It's early diastolic. They call it a diastolic blow, if you want to term. Once you hear it one day, you will, or on a recording, you will know how it sounds. So this is just a phonocardiogram of what I just explained to you. What's the clinical course? As we said, when you have compensated load on the ventricle, whether volume or pressure, patients don't have a lot of symptoms, though their heart has enlarged. So if you do chest X-ray, they may do an X-ray one day and somebody will tell them, قلبك كبير, but the patient has no symptoms. You do an echo, you find the heart is enlarged. And why is that? Because there's a right shift in the pressure volume curve. So the heart has moved to a new curve on the right. It can fill more without a rise in left ventricular diastolic pressure. And it will eject more, so we'll have normal forward flow. Occasionally, this is just for academic interest, you can have angina. Why? Because the diastolic pressure in the aorta is now lower. Why? Because what helps maintain the diastolic pressure of 80 in our normal situation is the fact that the aortic valve is closed. Now, when the aortic valve is leaking, blood is going back into the ventricle in diastole, so the diastolic pressure in the aorta tends to be lower. Maybe instead of 80, it will be 60 or 50 millimeters mercury. As in any case of hypertrophy, you get, after a period of compensation, you develop LV dysfunction, and this is bad. So we have to operate before left ventricular dysfunction sets in. In the case of aortic regurgitation, we have some numbers to remember. In the ventricle by echo has an end diastolic diameter and an end systolic diameter. So in systole, of course, the ventricle becomes smaller. The number that we have to remember is that when the end systolic diameter is around 5 centimeters, then the patient starts developing risks of heart failure. So we have to operate before the patient reaches this level of 5 centimeters. This is just another example of how pressure versus volume overload both lead to hypertrophy and both end up in the decompensated state. So in patients with aortic regurgitation who are asymptomatic and have normal systolic function, if you notice here, progression to symptoms or LV dysfunction is not common, less than 6% per year. However, if you follow the left ventricular end systolic dimension by echo, you notice that those who have an end systolic dimension more than 50 millimeters, they have a pretty high incidence of development of LV failure or death, 19%, which is not good. While this is almost like normal people when the left ventricular end systolic dimension is less than 50 millimeters, 40 to 50 in the second line. However, if they have LV systolic dysfunction, even if they don't have symptoms, they have a 25% chance of developing symptoms of heart failure, and the mortality rate is more than 10% per year. So these are the things we want to avoid. Left ventricular systolic dysfunction, which another way of looking at it would be when you have a left ventricular end systolic diameter of more than 50 millimeters. This also to reiterate what I just said. And when do we recommend surgery? This is from the American Heart Association, American College of Cardiology. When the patient has symptoms with aortic, and the symptoms are due to aortic regurgitation, you should operate. If they are asymptomatic, but echo shows LV dysfunction, you have to operate. Or if you have left ventricular end systolic diameter of more than 50 millimeters. This is another way to look at it, the survival curve. The black line is when their end systolic diameter is more than 55 millimeters, which is a poor prognosis, and you should not wait till then. This is the final slide, just to reiterate the difference between early and decompensated stage of aortic regurgitation. Early, they may have hypertrophy, dilatation, etc., but they will not be symptomatic because the left ventricle has shifted to the right, the curve has shifted to the right. Wherever, when they develop systolic dysfunction, then trouble sets in. Thank you.